Okay, students, here we go into skull positioning. I know how excited you are after learning all this skull anatomy. So the things to consider is the size and shape of the skull, the general body position of the patient, and we need to take a look at how clean everything is in addition, and protecting our patients, of course. So we are going to talk about where the gabella, inner canthus, outer canthus, nasion, infraorbital margin, the acanthion, the goyon, the mental point, the EAM, our auricular point, and the TEA, which is top of the ear attachment. So when we look at this diagram here, first thing we're going to start off with is the mid-sagittal plane. So this is your mid-sagittal plane. It cuts the body into right and left halves on the skull. So when we look at the mid-sagittal plane, right down the middle, we have the inner pupillary line here. So the two big things that we're going to talk about when we're positioning the skull, the facial bones, the mandible, anything, is your MSP, which is your mid-sagittal plane, and your IPL, inner pupillary line. So here, IPL. So we're looking for tilt and rotation from these two lines here. So your gabella, and I consider the gabella like right between the eyebrows, and the nasion is kind of where this cross is right here. So we have the gabella and the nasion. So we have the inner canthus with the outer canthus. Here's your nasion right there. You have your acanthion right where your nose and your upper skin comes in to where it starts to head out towards your nose. That's your acanthion. You have your mental point, which is your the point of your chin, the angle of your mandible, which we're going to call the goyon, and you have your infraorbital margin right down here. So IOML, so is going to be a line that we're going to use quite a bit along with your outer canthus, which is your OML. So it's important that you know where your outer canthus is, your infraorbital margin is, your goyon, mental point, acanthion, nasion, gabella, inner canthus, outer canthus. So the lines that we're going to talk about is the orbital meatal line, so the OML is from the outer canthus to the EAM. Your infraorbital meatal line, and as you can assume, it's just below the orbital meatal line, and that's your IOML, and that's from your infraorbital margin to your EAM. Then you have your gabellomeatal line, which is your GML, and is from your gabella to your EAM. You have your IPL, which is your inner pupillary line, so it's perpendicular line between the pupils of your eyes. There's the acanthomeatal line, so the AML, which is from the acanthion to the EAM. So your EAM is your base, and then it angles to whatever an anatomical part. So the acanthion, so it goes from your EAM to your acanthion. You have your mental meatal line, so that's your MML, is the from mental point to the chin. So to your EAM, sorry. So here, if we look here, we have the gabella or velar line, which comes straight down from the gabella to your acanthion. So this line is going to be important when we're looking at your SMV position. I know all these acronyms, hang in there, you're going to get the lingo down. So here is your EAM, so external acoustic meatus. So with your external acoustic meatus, we're going to your gabella meatal line, so your GML, so right here. Then we have your orbital meatal line, and you can see here it goes to your outer canthus, and you can see it's about 7 degrees, 8 degrees, and then 7 degrees to your infraorbital meatal line. So here's your IOML just below that. It's okay if you consider this 7 degrees. It's 8 degrees, but for ease sake, we consider this about 7 to 8 degrees. So here, we're going down to your AML, which is your acanthomeatal line, and this is your acanthion right here. So gabella, nasion is right here. Then you have your acanthion and your mental point. So then you have your EAM to your AML to your acanthion, which is your AML, your acanthomeatal line, and then you have your MML, which is your mental meatal line. So as you can see, this is about 7 degrees, 7 degrees. So we've got a swing in there. So you're going to have to be able to calculate the difference, if you can't hit your OML and you're supposed to be at your OML, you're going to have to figure out what the distance is and try to figure out how to correct the angle. Okay, so this is your mid-sagittal plane here on a patient that's prone. So you can see your mid-sagittal plane has to be straight. And you can see here the patient laying supine, and this is your mid-sagittal plane. All right, so based on skull type and shape, we have to adjust the patient so that we can get our CR entering and going through the body the way that we want it to. So the patient, typically for any skull work, we want them upright. So there are times where the patient's on a backboard or they can't sit up, they're too unstable, and we're going to do it supine. But if you have an option, you're going to want to do everything upright. It's important to know your body type that you're dealing with your patient, and I'll show you why. So, oh, awesome. I love it when it slides in like that. So when we're looking at the table, if we have someone with really big shoulders or really narrow shoulders, the patient's going to kind of roll into weird positions. So this is just using the table when you're positioning for a skull, and this is upright, just so you guys know the difference. And you have your hyposthenic and asthenic patients need support at the chest to elevate the cervical spine, so it helps prevents the downward tilt of your MSP. So your MSP always needs to be straight, with your IPL needs to be straight in addition. So hypersthenic patients require loosened support under the head, so it helps prevent the upward tilt of the MSP. And I'll show you what I mean here in just a minute. So review again, here is the MSP and here's the IPL, and we want to make sure in either table or upright buckies that we are completely straight. That is really important. When we do your lab practical, we're going to check and see that your MSP and IPL are straight. So that's the biggest thing. So if you see here, you have your hyposthenic patient, and you can see how your MSP is angled. So that's not good. We have to fix that. The easiest way to fix it is put a bolster under their chest, and that brings their head up so that your MSP will be nice and straight. And you can see here for hypersthenic patients, or patients that are very big, you can see how your MSP is tilted the other way, and you've got to fix that by putting a sponge under. Does this cause magnification? Yes, it does. But you know what? You have to get that MSP straight. So it's really important to get that MSP and IPL in the perpendicular or parallel plane. So here you want to make sure that you bolster this up so that it's nice and straight. So you can see that right there. So big difference. Don't go off of the nose. A lot of people have crooked noses, and it will definitely screw you up. So make sure that you're looking at the whole bony structure from the glabella down to the mental point. So you can see here this is nice and straight, and you've got the IPL straight in addition. Okay, so here on hypersthenic patients, you're going to have a problem getting your OML in the proper line. So you can also put a sponge under to get the OML nice and straight. So this is usually where you want to be. Sometimes the patient falls right into position for a view because they have a lot of fat behind their back, which is causing their head to rock back, which ends up being perfect. So for like a Waters, it works out nicely. All right, so you need to make sure that the hair and skin, the face, they're naturally oily, so you need to make sure you clean everything really well. Especially if the patient's going to be touching the board. It's really gross. You're going to be touching people's faces and hair, so you need to make sure that you wash your hands and make sure that you're nice and clean too. Protect the patient, so you're going to want to go ahead and collimate. Number one, that's the first thing we want to do. You can put a thyroid shield on patients. I've done that before quite a bit. I'll bring a shield right up under their chin to cover the breasts on females also, so I'll cover the thyroid and the breasts in one shot. All right, make sure the patient removes earrings, rubber bands, braids, ponytails, dentures, partials, hearing aids. If the dentures are all plastic, they're usually fine. A lot of the times they'll have a piece of metal in there that they didn't know about. You'll see it. They need to remove their hearing aids. They need to take out all jewelry. Then you take out any wigs or hair pieces, hairpins, barrettes, anything. Prosthetic eyes, if they're glass, it's fine. If they're not glass, you're going to have to ask them to remove them. So that is quite an experience. I've had to do that a few times and it just gives me the willies. All right, so these are the projections of the cranium. We have the lateral, and then we're going to talk about different ways that you can get the lateral projection. So don't freak out. The centering is exactly the same, and the MSP and IPL and all that is exactly the same. It's just different ways to get it, okay? There's the PA. There's PA axial, which is called Caldwell. There's the AP. There's the AP axial. There's the AP axial Towne's method. There's the PA axial Haas method. And there's the segmental vertical SMV. So we just call it the SMV. And that we use for the cranial base to see if there's any fractures of the cranial floor. All right, so the lateral projection. We want the patient typically upright. We want to see if there's air fluid levels within the skull, okay? So typically we do it upright, but you can do it recumbent, anterior oblique also. So the MSP of the head is parallel to the image receptor. The IPL is perpendicular, so you need to know which way which one's going. And you want your IOML parallel to the transverse axis of the cassette. So, and I'll show you what I mean by that. So the CR is coming in perpendicular to the IR. The CR enters 2 inches superior to the EAM, and then you're going to collimate on a 10 by 12 cassette. So this is with the patient in the dorsal decubitus. You're going to elevate the head or support it, so you have the patient with the MSP and the IPL straight. So the MSP of the head is vertical, the IPL is perpendicular, the IOML is parallel to the transverse axis of the cassette. The CR is horizontal and perpendicular to the center of the IR, and you're going to enter 2 inches superior to the EAM. So 2 inches superior to the EAM for a lateral skull. You're on a 10 by 12 cassette. Okay, so this here is for supine, recumbent oblique. So elevate the head, you're going to turn towards the side of interest, you're going to have the CR coming in perpendicular 2 inches superior to the EAM, and you're going to collimate to 10 by 12. So there's multiple ways to get this view. You need to figure out what is best for the patient. So here is an upright, and as you can see here, we've got the MSP here parallel to the IR. You have your IPL perpendicular, right? It's coming into it nice and straight, perpendicular. You're centered 2 inches superior to the EAM. 2 inches superior to the EAM. You need to make sure that you don't clip off the top of the head, the frontal bone, the occipital bone. You need to put a marker up there and you're good to go. So you can see here your MSP and your IPL need to be nice and straight. And here is supine. So this is a prone recumbent position. So same thing, you're going to go in 2 inches superior to the EAM. You want your IPL perpendicular and your MSP parallel, and you want it straight. So you can see here, nice and straight, both lines. And what we're looking for a good lateral skull is we want the orbital plates here, so the supraorbital margin. We want these superimposed, these plates. They need to be superimposed. Here we have your EAM, and you have an EAM. So this is a right lateral, so as you can see, this left EAM is bigger. It's magnified because it's further away. So you can see here we have some tilt. So what this means is the patient's head is going towards the board. So your MSP is not straight. So this is pretty much just tilt. Now rotation on the EAMs, one would be in front of the other. So if there's tilt, one's higher than the other. So you can figure out which way it's going based on the size of the EAM. So here, if we had rotation, it would be front or back. And top to bottom is tilt. So we have the sella-turcica here, external acoustic meatus. We have the temporomandibular joint right here. And we have the petrous portion of the temporal bone. We can also look at the rami to see if there's any tilt or rotation. So when we start working with the facial bones, we look at the ramus, we look at the orbital plates, and we look at the EAM, and to see if there's any tilt or rotation, because you're going to have to be able to identify which one you have. sorry, hold on. Yeah, right lateral skull. I was like, what? So this is a left lateral skull. Threw me off. Sorry, guys. So this one here, the orbital plates are off by a little bit. You can see just a little bit off. Here's your sella turcica with your dorsum sella. And you can see here, so this is your right EAM. This is your left EAM. Why? This one's bigger. It's magnified, right, further away. So we've got a little bit, it's starting to kind of shift. It's not straight up and down. It's a little bit off. So we've got tilt and we've got a little bit of rotation. You can see these plates aren't lining up exact also. And if we look at the mandible, it's off by a little bit back there in addition. All right, so here we are with your dorsal decubitus lateral skull. And you're going to want to use a grid with these. They turn out much nicer. Now, we usually do this position when the patient is on a blackboard and is on a backboard and in a collar. We do that to see if there's a skull fracture. So we'll just shoot this real quick, and if we have air fluid levels within the skull, we know that we have a problem. There's some kind of bleeding in here. If there's air, we're really concerned because then there's air getting in through the base of the skull, which is not good. So here you can see we have a fluid level, some kind of effusion. It's most likely blood. So we've got a fracture somewhere that we need to be very careful with this patient. They usually go straight to CT from this point. All right, so here's another way to get it. You can see we've had to bolster this patient up on a sponge. So we have a sponge here. So we have our IPL perpendicular and we have our MSP parallel, nice and straight, and we're going 2 inches above the EAM. All right, so PA and PA axial. So this is your Caldwell. So we have a PA with 0 degrees and we have PA axial, which we're going to put an angle on. So you have the patient seated erect or prone. Your MSP is centered to midline. Your forehead and nose resting on the table or upright bucky. So forehead and nose touching. You want your OML perpendicular to the IR plane. The MSP perpendicular to the IR and the IR centered to the nasion. So you're going to center this at the nasion. So for the PA projection, it's your CR is coming in perpendicular and you're just going to exit at the nasion. So you have no angle. You're just coming in straight and you're going to exit at the nasion. So put your crosshairs right at your nasion and have everything line up coming in nice and straight. So for the PA axial, when we say axial, we're talking about putting an angle on there. So when you hear the word axial, it's an angle, okay? So if we just say PA or AP projection, no angle. If we say PA axial, it's an angle. So that's what we call a Caldwell. So we're going to angle 15 degrees caudal. So we're going to go caudad. So we're going to take 15 degrees, head towards the feet, exiting the nasion. You're still on a 10 by 12 and you're still going to collimate to the patient's anatomy. So here, this is just a PA with 0 angle. Don't look at how their bucky's not lined up. Don't do that. They're off. So, oh my goodness. So here, we're going to exit the nasion. So you want your OML perpendicular and you're going to exit the nasion, okay? Now you can see how in the real world we would actually shift up a bit. We do not want to expose all the way through his apices and get his whole C-spine. So when we talk about positioning for the skull and the facial bones, what we're going to teach you is what you need to know for your national exam. That is going to change when you're in clinic. If you shot this in clinic, I would cringe. I would want you to shift up and collimate in nice and tight just to the skull, not the C-spine. I don't want to see the apices. All right. So when we're looking here, we have parietal bone on both sides. We have your frontal bone. You have your dorsum sella with your superior orbital margin here with your petrous ridges coming through here. So the petrous ridges fill the entire orbit. So we have the ethmoid sinuses, the crista galli sticking up right there. All right, so that's what we're looking for with 0 degrees. Here we have the PA axial, which is a 15-degree caudal. So you have your OML perpendicular, so you can see your OML is perpendicular, and you're going to be exiting the nasion and you're coming in at 15 degrees caudad. So here you can see this is a 0 angle, this is 15 degrees. You have your OML and you're coming in, exiting the nasion right there, and you want your MSP nice and straight. MSP and IPL. So on the table, this is what it would look like. Here's your 0-degree angle right here, and here's your 15-degree. Here's your OML, and you're exiting the nasion, MSP straight. All right, so this is your 15-degree, and you're going to have your petrous ridges in the lower 1/3. So you have your funnel sinus, your crista galli, your superior orbital margin, you've got your ethmoid sinuses here, superior orbital fissure, oh, right there, and you have your petrous ridges in the bottom third. And here's your inferior orbital margin right down here. So different than a zero. Zero angle takes up the petrous ridges, will fill your orbits, whereas on the 15-degree caudad, on the PA axial Caldwell, you have them in the lower 1/3. So if you have them filling the orbits, you need to be able to tell the difference and say that's a zero angle. So be sure you can tell the difference. So this is just a different way of getting it. Roll them up on a sponge so that you can get your MSP nice and straight. His looks still obliqued a little bit. His IPL looks a little off. In a trauma situation, you just get the best that you can get, okay? All right, so we were just talking about PA axial projections. Now we're going to go into the AP and AP axial projection. So the difference is you're going from PA now to AP. So on your AP axial, what we're going to be doing is angling the opposite direction, right? So they're similar, but the AP, you're going to have magnification of your orbits, right? So for the patient and part position, they're going to be supine or upright. If you can do it upright, you should be doing PA, right? So this is typically supine, MSP center to midline, and your MSP and OML perpendicular to the IR. Your for the CR is perpendicular, so 0 degrees, or 15 degrees cephalad for AP axial. You're still at the nasion, so you enter at the nasion, and it's a 10 by 12, and you're going to collimate to the anatomy. So you can see here, you have your OML here, and you're coming in at your nasion, so you just consider the light going straight through, okay? So that's the easiest way. So you want your IPL straight and your MSP straight. So for your axial, so your AP axial projection for your Caldwell, you're going to go 15 degrees. So here is your OML. So you are going to angle 15 degrees from the OML. So you're going to take this and you're going to do 15 degrees from it and entering at the nasion. So he's a little high, so come down just a hair. I'm being picky. All right. So this is what it looks like. You have magnified orbits, and this is the 0-degree angle. So this is just straight, and you can see that the petrous ridges here fill up the orbits. All right, so the Towne's method. So AP axial Towne's. The patient is supine or seated erect. The MSP is centered to midline. MSP is perpendicular to your IR, and your OML or IOML is perpendicular. And we're going to talk about the angle differences between the two. And I pointed that out earlier, but we're going to show you where this comes into effect. So you want the IR, so your image receptor, the top border level with the skull vertex. So you want the top of your IR at the top of the skull. So your IR is centered at or near the foramen magnum, and you're going to enter you're going to have the light come through or near your foramen magnum, which is about 2.5 inches above the glabella and passes through the level of the EAM. So you can do it either way. I know Jeremy and I both accept both answers. So the CR is directed through the foramen magnum. So if you're at your OML, so if you have your OML lined up, it's a 30-degree caudad angle. If you're at your IOML, it's a 37-degree caudal angle. So the difference between the OML and the IOML is 7 degrees. Remember, it's 8 degrees going up to the glabella. So you somewhere around there. We're not exact, but for your national exam, they're going to be requiring that you know the difference between the two. And I think they put 7 to 8, but you know, there you go. Okay, so here's your OML. So the patient's upright. You can see that the top of the film, or the film, how old am I? The IR, the vertex, you can see it right there. So you're right at the top. You're about 2.5 inches above the glabella, passing through the EAM to the foramen magnum. So with your OML, you're going to go 30 degrees caudad. So 2.5 inches up, 30 degrees caudad, passing through the EAM. So they're a little high. Come down just a hair and you'd pass through here, right through the base of the skull there. So looking here, we have your OML, and we're going 30 degrees through the EAM, 2.5 inches above, through the EAM, through the foramen magnum. So if we're going to go IOML, you're going to go 37 degrees coming down through. Okay, so same idea, same positioning, just different angles based on what line you are centering from. So here, this is supine, you've got your OML, and we're going 30 degrees, so here's straight, 30 degrees from the OML. And that's a big 2.5 inches, you think? I think their measurement's off. I go about right there, bringing it through, so that would bring it right through your EAM, through your foramen magnum. So I think they're a little high in this diagram, just so you know. All right, so same idea. You have your OML and your IOML, and we're going 30 degrees versus 37 degrees. And this is what we look like when we're done. So this is a 30 degree, and you can see here, we've got the parietal bones, occipital bone, your foramen magnum here. So if I point to this and I have dotted lines going around, that's your foramen magnum. If I'm pointing to this inner structure right here, this is your dorsum sella. And then you have your posterior clinoids out here. All right, and this is your petrous ridges on the sides. So here we have your dorsum sella, your posterior clinoid processes, and petrous ridges, foramen magnum. Okay? So this is a trauma case, and we're going to study trauma later on. And this is looking, you can see here, pretty close to your IOML. It's more a canthion, so you would have to calculate for your canthion on your angle. Okay, so a lot of times I'll just take the central ray and I will line it up so it's coming in straight, and then angle based off of that. I'd calculate the angle based off of that, how far off I think it is. Okay, and we'll talk about that when we get to trauma more so. Okay, so this is an angulation for trauma. To see the foramen magnum really well, we will sometimes angle between 40 and like 60 degrees depending on what we want to see. So here, if you're at your OML, if we go 45 degrees, you're going to see here we have a lot better view of the occipital bone and of the foramen magnum. So you can see the posterior arch is C1, and we've got a mandibular condyle, petrous ridge, your perfect view of your foramen magnum. It's a great shot. And then if we go 55 degrees, excuse me, really good for the foramen magnum, so it's even better. So it depends on what they want to see. And through here, sometimes we can get the odontoid through here. So here's the dens right here. And then here's your posterior arches C1. So really good shot right there of your foramen magnum. Okay, so here is an apiaxial skull with the patient lateral decubitus with the IR and grid. Vertical. So look how old this system is. Wow-wee. Anyway, so this is the same idea. It's just a different way to capture it. If the patient's not able to stand, or they're too kyphotic to actually, or to do it with them supine, this is another option. So I'm just showing you other options. Everything else stays the same. So your IPL, MSP, your 2.5 inches above, all of that stays the same. Okay, so here's your PA axial, which we call the Haas method. The patient position, so they're seated or upright. MSP is centered to midline, shoulders in the same horizontal plane, and your forehead and nose are on the table, and your MSP is perpendicular and your OML is perpendicular. So your CR is directed cephalad at 25 degrees to the OML. So it enters at a point 1.5 inches below the external occipital protuberance and exits 1.5 inches superior to the nasion. All right, so what does this look like? Here we go. This is Haas. So patient is prone, or it's a PA. You have your OML, and you're going to go 25 degrees from the OML cephalad. So here we go. You have your OML, and you're going 25 degrees, and you're going to go 1.5 inches below the occipital protuberance, exiting the patient 1.5 inches above the nasion. So 1.5 inches below the occipital protuberance, external occipital protuberance, and 1.5 inches superior to the nasion. So you can see here 1.5 inches below, 1.5 inches above. 1.5 inches below the external occipital protuberance, 1.5 inches above the nasion. 1.5, 1.5. All right. You can see here this is upright. So you have 25 degrees. You're going cephalad. So you have the 1.5 to your external occipital protuberance. You have your OML and your 1.5 inches above. So if you're using your infraorbital, you have to calculate out 7 degrees. All right. So here you have your occipital bone. You can see really well your parietal bones here, and we've got your, we can see your saddle here. So we've got the posterior ridge, this is your foramen magnum. Within your foramen magnum, we have the posterior clinoids right here. You can see them perfectly. We have the dorsum sella, which is the posterior portion right there. And this is your sphenoid sinus right there. So it shows us if there's any fluid or anything in there. All right, so you can do cone down views to see the sella turcica using the Haas method. You have to be pretty good. So you can see here, we can see within there really well. So here's your foramen magnum. You've got your petrous ridge with your mastoid air cells, your posterior clinoid processes on either side with your dorsum sella here. So if I asked you to label this, I had dots around here, foramen magnum, dorsum sella, clinoid processes, posterior clinoid processes, petrous ridges, mastoid air cells, and then your sphenoid sinuses right there. All right. This is your last projection. This is your SMV or the Schüller method. So the patient is seated or upright. So be careful if the patient is seated or upright. You need to be really careful with the patient. If they're laying down, if they're supine, you need to make sure that the torso is elevated. So your MSP is center to midline. Your IOML is parallel with the IR, and I'm going to show you what I mean by that. Your MSP is perpendicular to the IR. So your CR, it goes through the sella turcica, perpendicular to the OML. So I'll show you how that works. Enters the MSP of the throat between the angles of the mandible. Passes through a point 3/4 of an inch anterior to the level of the EAM, and you center the IR and the CR. So you collimate to a 10 by 12. This is what it looks like. So you have your IOML parallel to your image receptor. So they're in the same plane. So you want this cranked all the way back so this patient has a parallel IOML. You're going to enter between the goyons. So here, you can see here we have the IOML and your central ray coming through the angles of the mandible, coming right through. So they also say passes through a point 3/4 of an inch anterior to the EAM. So you can see it's not quite 3/4, that'd be about right there, right? So they're a little posterior. And so here's your EAM right there, so that's about right. And here's the angle of your mandible, so that works. Laying them down, so you can see how you have to bolster the shoulders up to get the head to drop back. Now, when you get to the sinuses and the facial bones, you're not supposed to angle your tube when you're doing this on a lot of views. This is the only view you are allowed to angle the tube. So if you're doing a sinus, you can angle on the SMV for any view you need for the SMV. Just keep that kind of stored in the back of your brain. So here, you can see that we're off by quite a bit. So we're not angled quite right. So you're going to angle your tube to compensate so that your infraorbital meatal line and your tube are coming in perpendicular to each other. So this line right here needs to perpendicular your tube angle, okay, so that you get a true SMV view. So here, your infraorbital meatal line and your CR, you're going to angle so they're coming in at 90s. You can see here, this is your SMV, and this is what you're looking for. If you're doing it for the skull, You probably should not clip off the back, so it should look more like this. So if you're doing it for the skull, don't clip it. If you're doing it for facial bones, you're going to clip it right here. You're going to cut it right across. So here is your maxillary sinus, and we have the ethmoid air cells here. This is your mandible, so this is your goyons here. So this is your angle of your mandible or condyle. And we have your, what I want you to know here, sphenoid sinus, so ethmoid and sphenoid. And this is your dens or odontoid process. Pars petrosa, or your petrous ridges, mastoid air cells, and this is your occipital bone with your foramen magnum right in here. Okay, so you can actually see your zygomatic arches here. So you're going to do this view for those in addition. All right, so that is all of your positioning for the skull. You're going to want to go through all of this a few times. Jeremy's going to work with you in addition, and you're going to practice imaging and seeing the tilt and rotation. You'll also have to do your image analysis book. So be sure to study up what you're supposed to see in each view and how it's supposed to be displayed. So memorize your lines, your glabella meatal, orbital meatal, infraorbital meatal, acanthomeatal, mental meatal. You need to know your MSP and your IPL, and we're going to use that lingo moving forward. All right? I'll post your quiz soon.